So just going through some variables of these cardiac potentials. So first off, what happens if there's sympathetic stimulation? So again, let's look at the pacemaker potentials. The pacemaker, we're talking about SA node, we're talking about the AV node. So the SA node, we can stimulate that with beta 1 stimulation. Remember, this is going to be a G protein coupled receptor. It's going to increase CAMP through your GS pathway. Increased permeability of inward calcium current increases the heart rate. So for one, if you give a patient epinephrine, right, epinephrine would directly stimulate that beta 1 receptor and lead to an increase in the calcium current. And remember, the calcium current is responsible for the depolarization of the pacemaker cells. Now, what about if I gave a patient hydralazine? What would happen if I gave a patient this drug? Well, we know hydralazine is a vasodilator. Okay, so it's primarily an arterial vasodilator. So it's going to vasodilate, and that's going to cause a decrease in my MAP, right? It's going to decrease my diastolic blood pressure. And when that happens, my baroreceptors are going to recognize that, right? My baroreceptors, we already talked about these guys. They're going to recognize that, and the baroreceptors then are going to respond to that decrease in pressure by increasing my heart rate, and that's through beta 1. Okay, it'll be the same concept, and it'll do that by increasing the permeability of inward calcium current through a sympathetic response. Now, if you had parasympathetic stimulation, on the other hand, so again, this is going to be the opposite. Parasympathetic stimulation is going to be more of your vagal tone, right? And so that's primarily through the M2 receptors, decreases in CAMPs, just the opposite. Decreased permeability of inward calcium current lowers the heart rate. Now remember that sympathetic stimulation doesn't just affect the heart rate. I'm just talking about the heart rate because we're talking about pacemaker potentials. But if we were talking about non-pacemaker cells, remember sympathetic stimulation would actually cause increased calcium intracellularly in those myocytes, and that's calcium-induced calcium released, more calcium, again, to bind to troponin C to move tropomyosin out of the way and cause higher contractions when myosin and actin can interact. Okay, so sympathetic stimulation will not just have effects on heart rate, it will also have effects on contractility, and it will do so all based on the calcium, right? So it's all kind of surrounding this calcium. The calcium current is responsible for the depolarization in the pacemaker cells, but the calcium is also responsible for contractility in that it binds to troponin C inside of these myocytes that are non-pacemaker cells. Classic sodium channelopathy is going to be the Brugada syndrome. Now, what I want you to remember here when we're talking about this specific point is that we're primarily talking about non-pacemaker potentials. Again, you kind of have to know, which one you're talking about. So in non-pacemaker potentials, there's an impairment of the inward fast sodium current. Again, there's only the inward fast sodium current in non-pacemaker cells. Pacemaker cells, again, will have the slow sodium current. And again, this is responsible for phase 0. Phase 0 is always going to be depolarization. It's going to be the rapid depolarization. So if I had some defect in this channel, right, I would have some issues with depolarization, particularly the rapid upstroke of depolarization that is happening during an action potential. The curve is normally going to look something like this, right? And so, again, we're talking about this phase right here. Okay, so there's going to be some defect in this phase where I'm not able to conduct this current very well. And so what happens is I end up getting kind of I'm going to draw it over here, I'm going to end up getting kind of a slower upstroke that looks like this. This slower upstroke is a real problem because it's actually going to decrease my peak current. My current might only peak at about this height. And when I decrease peak current, I end up getting short circuits. Not all of the cells are going to get that current and then get an action potential. Remember, I told you for non-pacemaker cells that you have to be in an adjacent area and get some kind of external stimulus to undergo an action potential. If you're not in an area, if those Purkinje fibers send a signal, but my cells are not able to conduct those sodium channel depolarizations well, then the cells around them might not get depolarized. So some areas of the heart might not get this electrical stimulus. You get these kind of strange blocking waves that form in Brugada, and some of the findings you see, the classic findings, are going to be ST elevations in V1 through V3 and a pseudo-right bundle branch block, which we'll talk about in more detail. Usually you won't have to analyze an EKG in great detail on step 1. This is more step 2, but these are things just to kind of be familiar with as they do come up. All right, finally we have our QT prolongation. And the thing to remember here is that the sodium channelopathy, the Brugada syndrome, which by the way I also forgot to mention, it's autosomal dominant, is very similar to some of the QT prolongations, but the thing that differentiates it is the channel that's involved. So again, this is sodium channelopathy for Brugada syndrome, whereas with QT prolongation, it's primarily going to be an impairment of the voltage-gated potassium channel, specifically, like we talked about, the delayed rectifier potassium current, which again, this is going to be responsible for hyperpolarization. So you get a delayed ventricular repolarization. So again, if we're trying to compare this, right, so it would be something like this. So here's my original curve, and essentially what's happening is I'm affecting phase here, the repolarization. And so if I delay my ventricular repolarization, it might look something like that. Okay, so this is going to be a longer ventricular repolarization. But remember what I told you, this area from about here to here, when we get back to resting potential, that's the QT interval, right? I told you that this is the area where we have the QRS, and then we have a repolarization, that's going to be your T wave. Okay, and so this QT interval between the space, it gets a lot longer, right, if I have a delayed repolarization. Okay, so that's going to cause a longer QT interval by having impairment of that delayed rectifier potassium current. And this can lead to a very high yield arrhythmia known as torsade de pont, which is essentially twisting of the peaks. It's a type of polymorphic ventricular tachycardia. Listen to what I just said, polymorphic, right? So it's going to be all different shapes. So you can see there's all different shapes in this tachycardia. It kind of goes up, and then it goes down, and then it goes up again. So there's all different shapes. Now, a monomorphic tachycardia would have all of these shapes looking very similarly, so they might all look like this. But a polymorphic ventricular tachycardia, you get this kind of oscillating intensity in these peaks. Okay, so they're all kind of different heights, different shapes, so to speak. That's very classic for torsades. Okay, and this can lead to sudden cardiac death because we're not ejecting blood proficiently to different areas of the body at these very high heart rates because we're not ejecting blood very efficiently, right, during these states. And I'll talk more about this in the arrhythmia section. But the classic congenital forms of getting this QT prolongation that we're talking about here is the Romano-Ward syndrome and Jervell and Lange-Nielsen syndrome. So Romano-Ward, just like Brugada, is autosomal dominant, and the Jervell and Lange-Nielsen syndrome is autosomal recessive. The thing that differentiates these two, the other big thing, is the congenital bilateral sensorineural hearing loss, which you see with the Jervell-Lange-Nielsen syndrome. So they usually talk about this in some way in the question stem. The other thing you can sometimes see are these drug-induced forms of prolonged QT syndrome. Now, prolonged QT syndrome is extremely high yield overall. The problem with this is so many things cause prolonged QT. So we can sit here with a list of 5 or 6 pages long of things that cause prolonged QT. But this is the way I remember it, and I think this is seen in a few resources here. But I like this where it's A, B, C, D, E, F. So A is for anti-arrhythmics. Now I put this one on here just because if you're kind of in a rush and you can't remember all of these, it just makes it a little bit easier to just kind of go through, what's one classic one that's associated with this. So anti-arrhythmics, in general, the class 1A anti-arrhythmics and some of the class 3s cause this, but the big one is quinidine. And I put some of the other ones on here for your review. Antibiotics is the B. Macrolides is very classic. Antipsychotics, so you think about the C, antipsychotics, antipsychotics, however you want to remember that. Haloperidol, very classic. Antidepressants being the D. TCAs in general, also don't forget about methadone. That one comes up occasionally. Antiemetics, E. So I think about ondansetron, which is Zofran. Electrolytes are also very important to kind of categorize here with the E. So hypocalcemia, hypokalemia, and hypomagnesemia. So you can see it's always when these electrolytes tend to be low that you tend to have this prolongation in the QT. That might have something to do with the fact that you don't have enough of these ions around, whether that be the calcium in this stage or the potassium in this stage that's delaying this interval because you don't have enough of those ions around. And magnesium is responsible, really, maintaining normal levels in some ways of these ions. And so that's kind of how I remember it. If I don't have enough of these ions, I'm going to start to delay this and I can get a prolonged QT. Physiologically, there's more to it, I'm sure, but that's just kind of an easy way to remember it. And then antifungals, F for fungals, azoles are also very classic.